गाड़े सर, नमस्कार सर।
We are live.
Yes, Rahul, you can go ahead.
Yes, sir. Good evening, everyone. On behalf of VOS, it is my privilege to welcome you all for today's webinar. This session is a part of our initiative to have Wednesday webinars, and today is the third one in the series. We are delighted to have with us eminent panelists and respected senior chairpersons. Today we have special national guest speakers, Dr. Pradeep Mohanta sir and Dr. Saurabh Patwardhan sir, who are online with us. Dr. Patwardhan sir is the director of Nandadeep Eye Hospital and PG Institute, and he is head of FECO training and fellowships and chief mentor for FECO Tip 3D teaching courses. He is the pioneer in live streaming of surgeries on YouTube and Facebook, and he has more than 12 publications and more than 30 chapters in various books and journals. He is the inventor of the iTori Patwardhan hybrid chopper and 3D surgical weaving system, runs popular FECO teaching on YouTube channels, and he has his own teaching website, fecotraining.org. We have eminent surgeon Dr. Pradeep Mohanta sir, who has done his MBBS and MS from Calcutta Medical College and MS from the PGI Chandigarh Medical College. He is a fellow of Vitreoretina from Shankar Nethralaya, but presently he is also the scientific committee member of AIOS, and he is the founder of Netrajyoti Eye Hospital at Ranaghat. He is a comprehensive cataract surgeon, and he is a very expert, renowned teacher for advanced phaco techniques. He has trained hundreds of international candidates and innumerable national candidates. He has about 2,500 surgical videos on YouTube, and he has over 12 years of experience to mentor the cataract surgery courses. He all these I take this opportunity to express my sincere gratitude to our dynamic president sir, Dr. Viral Shah sir, whose guidance and encouragement has been driving force behind all our academic endeavors. With such an illustrious faculty and highly relevant scientific program, we look forward to have today's fruitful scientific discussion. I request Dr. Viral sir to have opening remarks about today's webinar.
Thank you, Chairman Scientific Committee, Dr. Rahul Tiwari. Excellent program conceptualized by your team, including Dr. Neha Deshpande, Dr. Dr. Naveen Soni, Dr. Nikhil Kandorwar, and Dr. Rohini Juneja. VOS this year has completed 50, is completing 50 years. This is the 50th year of our VOS, and we are celebrating 50 glorious years of VOS. And we are glad to have this Wednesday webinar series going on every month. And today's chairpersons, Dr. Satish Kothre sir, Dr. Umesh Tevanwar, Dr. Aparna Bhayati madam, and our co-chairpersons, Dr. Rajesh Joshi sir, Dr. Vijit Patil sir, Dr. Avijit Vaidya sir, and Dr. Durgesh Chole, with our esteemed panelists, Dr. Pavakar Patil sir, Dr. Arvind Gade sir, Dr. Praveen Vyavare, Dr. Gopal Arora, Dr. Shaunak Mukaddam, Dr. Sandeep Mungattiwar, Dr. Ashish Sapkal, and Dr. Akshay Bidkar. Our guest faculty is nationally and internationally renowned, Dr. Pradeep Mohanta sir and Dr. Saurabh Patwardhan sir. Both are FECO gurus to, I think, lakhs of ophthalmologists, not only in India, but all over the world. We learn so much from them. And this session is being moderated by our moderators, Dr. Naveen Soni and Dr. Manish Wankhede. So without wasting much time, I would request Dr. Rahul Tiwari to please start the proceedings of webinar and hand over to the chairpersons. Thank you, everyone. Thank you, everyone.
Thank you, sir. I request,
also, please, also our local faculty, Dr. Jay Bhopi and Dr. Subodh Purohit. I thank them for they have gracefully accepted to be faculty for this webinar. Thank you.
Yeah. Over to Manish and Dr. Naveen to conduct the further scientific proceedings. Our today's moderators, Dr. Naveen Sonia and Dr. Manish Wankhede, sir.
Hello, sir. Good evening, everyone. I welcome you all in this webinar on the cataract series on VOS Wednesday webinar. We have all the esteemed faculties, chairpersons, and moderators with the permission of everyone, let me start with this great scientific session. I think Mohanta sir is yet to join. Sir, we will like to, can we start with Dr. Purohit sir then?
No, Mohanta sir is there.
Mohanta sir is
Okay.
already there.
Okay.
Pradeep Mohanta sir is there.
Pradeep sir, you will be
Good.
presenting from mobile only?
So
Yes,
should
yes.
I have
Okay.
the
Okay, you will be
Okay.
playing. Okay.
Okay. Good evening, Mohanta sir.
Yes, yes. Can you hear me?
Yes, sir.
Yes, sir, clearly.
Okay.
should I share the video, sir, or you will be able to share from there?
No, please share. I have only mobile with me. I'm in a remote
Okay.
place.
Okay.
Mr. Sunil, I'll be sharing sir's video.
Mr. Sunil, while the video is being played, keep the spotlight on Pradeep's iPhone.
Is it visible?
No, this is Dr. Saurabh Patwardhan's slides.
No.
No, this is introduction of Dr. Saurabh Patwardhan. Exit. Now we share. You, Rahul, just get your presentation started on your laptop, then start the.
Yeah.
Yeah.
Yeah, sure. Okay.
It's visible, sir.
Yes.
Yes.
Yeah.
So
Should I start, sir?
shall I start?
Yes, sir.
Yes. So my topic is customized techniques for different grades of cataracts. Every cataract has demands its own technique. For very soft cataracts or for clear corneal extraction, you do only phaco aspiration, which means you don't need to use any ultrasonic energy. You just go, bevel down, start aspirating, and when most of the thing has been aspirated, towards the end, you just make the bevel up so that you don't catch the posterior capsule. So this is a very quick procedure, and it's done. This for soft cataract, another technique is the carousel technique. In carousel technique, you do hydrodelineation, rotate the nucleus very nicely, go with high vacuum, place the phaco tip at the edge of the golden ring, and very soon it comes to the tip. Then the stop and chop technique, every one of us knows this technique. In this technique, we just make only one trench. In divide and conquer, we make two trenches and make a plus sign. In stop and chop, we make only one trench. And in soft cataracts, this trench should be narrow and deep, should not be very wide. If it is wide, then there is bowl formation and you can be in a problem. So once you divide the nucleus into two heminuclei, just aspirate or just emulsify the two heminuclei. So this is stop and chop technique, divide and conquer technique. I am not going to show, but do one of us start our phaco with that technique. This is lens tilt technique. In this technique, you make a large rhexis. The rhexis size should be about 5.5 to 6 millimeter. And as you do hydrodissection, one side of the equator of the lens comes out. See this. It has come out, and now you inject visco this side and through the side port on the other side. Now you go with your chopper and support the posterior surface of this nucleus. Now go with the phaco needle and start hitting off the portion, supracapsular portion. 1, 2, 3, and then you crush the rest of the nucleus between the two instruments, that is your left-hand instrument and right-hand phaco handpiece. And then you emulsify the whole thing. For this technique, the thing is you have to have a large rhexis, otherwise the lens will not tilt. So this is not suitable for premium lenses. This is the technique for premium lenses where you can do a small rhexis, 5mm rhexis, and divide the nucleus in the bag with these two instruments. This pre-chopper has been designed by me, and the left-hand instrument that has gone through the side port is called nucleus sustainer. It has a ball tip, and now we come out, the antechamber, if the antechamber becomes shallow, we come out, inject visco, and again we can go with the pre-chopper and nucleus sustainer and divide the other pieces. So once the nucleus has been divided into 4 pieces or 3 pieces, we go again, inject visco, and go again with the handpiece. Now, this is the first time you're going into the antechamber with the handpiece. And emulsify the pieces. The pieces comes very easily to the tip of the phaco needle. Fallibility becomes very good because it is already nicely divided. Direct chop, all of us know, this is for cataracts which are grade 3 or grade 4. The one thing is the tip has to be nicely occluded. The tip goes into the substance of the nucleus, occlude the tip very nicely, hold the nucleus substance very firmly, and then chop. Without getting a good purchase, if you try to chop, it may not happen. So once you divide the nucleus into several fragments, start emulsifying the pieces. These techniques are good. You use less ultrasonic energy and the cornea remains very clear next day. Always remember in direct chop that you have to have a nice occlusion of the teeth, have a firm grip, and then chop. This is the submarine chop technique. I have many videos on YouTube on this technique. This is for harder cataracts, for grade 4, grade 5, nuclear sclerosis. So after a large rhexis and nice hydrodissection, the tip goes through the substance of the nucleus towards the opposite equator. As the submarine goes through water, it goes through the nucleus substance. Get a nice crack, rotate the nucleus 180 degree, come to the other side, and now go divide each heminucleus in the same way. Go through the substance, and after getting the pieces, you can hold each nuclear piece. I usually tilt the pieces, go to just behind the apex, and start emulsifying the piece. Ultrasonic energy is used is about 80%, and flow rate is 40 to 45, and vacuum is 400 to 450. This is the other heminucleus. Divide it into 2 pieces and emulsify. At the last piece, what I do nowadays, I remove the epinuclear shell and use the epinuclear shell as a contact lens to protect the posterior capsule. So this is the submarine chop technique for harder cataracts. And now, for intumescent cataracts, we have to, the most difficult part is the capsulorhexis part. The rest of the surgery is not difficult. So what I do is I do a small rhexis, and then I use a 23G Simcoe cannula, aspirate the cortex, and decompress the bag, decrease the intralenticular pressure. I aspirate very nicely rotate the nucleus, and all the loose cortex I aspirate and decompress it so nicely that there is zero chance when I enlarge this small rexis into an optimum sized one. Cut the margin of the rexis, take the uterate again, and always remember that in intumescent cataracts, needle is not the right instrument. Cystitome is not the right instrument to do capsulorhexis. We should use utreta forceps or microrhexis forceps, and we should do the rhexis. The rest of the surgery is simple. You can do direct chop or submarine chop or vertical chop, whatever you want, and then manage the nucleus. Intumescent cataracts can be very soft, can be grade 3, can be very hard. It depends. Sometimes we don't make out. If the patient is younger, usually it is soft. If the patient is very old, it can be very hard. And now, if the cataract is having a small pupil along with, then what to do? You can use iris hooks, and this is the BHEX device invented by Dr. Suben Bhattacharjee. It's a very nice thing. The thing is, the iris remains at its own plane. With iris hooks, there is some lifting up of the iris with iris hooks. But with this device, the iris is at its own plane, and we can, once it is applied, the rest of the surgery is simple. We can just do rhexis and manage the nucleus. Sorry. There's a newer device. It's called B-Octa. In BHEX, there we have 6 sites. In B-Octa, we have 8 sites. And B-Octa gives larger dilatation of the pupil. B-Octa can be used in SICS also. Nowadays, I use BHEX for smaller people, like if the pupil size is 3 to 4 millimeter, I use BHEX. And if the pupil size is 4 millimeter to 5 millimeter, and if there is IFIS, then I prefer B-Octa. So this is the small people. We have to use adequate ultrasonic energy. If the cataract is hard, we should use higher energy. And if the cataract is soft, low energy. And we should always protect the cornea, remaining far away from the corneal endothelium. After implanting the lens, this is how you remove the BHEX. No injector is required. So this is the customized techniques for different kinds of cataracts, cataract with small people, with intumescence. Thank you very much. Hello.
Thank you very much, sir.
It was a very wonderful presentation, and we are.
Yes. Can you hear me?
Yes, sir.
Yes, sir. Yes, sir. Yes, Dr. Navin? Manish?
Yes, sir. Thank you very much, sir. It was a wonderful presentation covering almost all the kinds of the cataracts, newer techniques, and particularly that particular chopper. Sir, can you please tell something about your new invention of the chopper?
It is a simple device. Pre-chopper has got, suppose this is the pre-chopper. The front base is the cutting edge, bottom is round, and the back surface is blunt. And the sustainer has a ball at the end, and it's a round bodied thing. So the sustainer hooks the equator and supports the lens. The pre-chopper goes through the main wound and it goes through the lens, and two instruments come to each other, and then you separate laterally. It's a very short learning curve. If you try in 4 or 5 cases, I'm sure you can do it. This is commercially available with me as well as with Joseph Surgicals. It's a very simple thing. So tip length is 1.8 millimeter from the bend, and the sustainer is 1.7. I have a longer sustainer also, 1.8, 1.9. I use those if the chamber is very deep. I use longer nucleus sustainer, and if the chamber is shallow, I use small, short length nucleus sustainer.
I have quick questions to Dr. Pradeep Mahanta.
Yes.
It's very nice. It's always a treat to watch your videos, Dr. Mahanta.
Thank you.
Just extending that question of that pre-chopper, as you've rightly mentioned, you just engage from the sustainer at the equator, and then when you engulf it or start your penetration, is it in the center of the nucleus or in the periphery?
In the periphery. The nucleus goes to the periphery, and the pre-chopper also just in front of the main wound, just in front of the rexis. You go there, and both the instruments are in the periphery. And it goes towards, this one comes to the center, and this one advances towards the center.
Yeah. And the second question is, since one of the technique is in your name, which is called the Mohantas technique, one thing I found in that technique is you have a bigger rexis. So the normal nomogram that goes is that you should, this rexis should actually cover the edges of the IOL. So if the rexis is big, it won't serve that purpose. Your comments?
Yes, that's why in premium lenses that lens tilt technique is not recommended. In premium lenses, you need a rexis which is 5 millimeter, and the rexis margin should overlap the optic of the intraocular lens. But this may not happen with this lens tilt technique. Lens tilt technique is for monofocal lenses, or if you have a sensor multi-piece lens where those lenses you can, it's okay. And for SICS, it's fine. But for other cases, for premium lenses, it's not a good thing to do. For premium lenses, you should do a small rexis and divide the nucleus with pre-chopper or whatever technique you are comfortable with.
Excuse me, sir. Can you hear me, sir?
Yes, yes.
So sometimes what happens when the nucleus is very hard and all the cortex which is liquefied around it's we absorb that cortex, and while try to catch the nucleus, it start rotating. So which is your trick to handle this situation?
Yes, in these cases, you make if you keep the bevel up, the phaco tip, if you keep the bevel up, you cannot engage. So keep the bevel down and go for a short length. Make a small tunnel from in the periphery, just in front of the rexis. From there up to the center, you just make a small tunnel and then come out. And then you can make the bevel up or sideways, whatever. And then you can go through that tunnel, and then it will engage. And you go a little forward, and then you chop.
Okay, okay.
I have some videos you can watch in YouTube, how to manage free floating nucleus. If you search in this way, you'll find those videos. Or I can share it to you.
Okay, thank you,
Dr.
sir.
Pra- Dr. Pradeep,
Yes.
Dr. Pradeep, don't you think that 0-degree tip is better for holding the nucleus rather than going for 30-degree tip? Because 0-degree tip holding is better even in your carousel technique. the holding will be better in a 0-degree tip rather than 30-degree tip. Why to bevel down? Just take up 0-degree tip and do the chopping, and even the carousel will do.
Yes, sir.
What is your
That is if the surgeon is used to a 0-degree tip, then it's fine. Otherwise, changing the tip, and if the surgeon is used to 30-degree tip, then it becomes a cumbersome changing
Yeah,
the tip.
that means it's a habit of the which tip you are using, right?
Yes, yes.
Yes.
So it is according to surgeon's comfort.
Okay. Thank you.
Okay.
Just to this
Should
point, I would like to say that you don't have a 0-degree tip in some phaco machines. Like Oakley, for example, doesn't come up with a 0-degree tip. So we are forced to
Even in
use either a
Oakley,
15
I
or
have a
a 12.
degree tip. No issue. You have to get it. You have to search
They
the world. You
have
will
stopped
get that
making
0-degree tip. No issue.
it. Okay, sir. Okay.
If you want, you can
Because
contact
when
me.
I
No
asked,
doubt.
they said that. Thank you, sir. Thank you very much.
Okay. Thank you for this
Just
wonderful.
one comment.
Yes. Yes, sir.
Just one comment on your first video. A very nice video, sir.
Thank you.
In very soft cataract, we don't have to put phaco probe inside. You can just aspirate with, if you have a unimanual phaco aspiration probe or bimanual aspiration probe. That does help in aspirating the cortex. This is particularly useful if you have a very soft nucleus with just a small posterior polar opacity. Because sometimes it may happen that you put your probe inside, and if surge happens, then there is always a possibility of catching the posterior capsule. Just a small comment, because
Yes,
what I
yes.
do, that is what I want to tell to everyone.
Right.
Sir, with this, should I go for a next presentation?
Yes, yes, yes.
Okay. Sir, next is our own VOS superhero, Dr. Subodh Purohit, sir. Sir is very famous for his presentations, particularly in premium IOLs. We have seen him, watched him, and learned him many things from Subodh, sir. Sir, please go ahead with precision in toric IOL. Subodh, sir.
Sir, please unmute.
Thank you, Manish. Dear Manish, for your kind words. Thank you, President VOS Dynamic, Dr. Viral Shah, for allowing us to hold this meeting on behalf of Yatmal Ophthalmic Society. And I'll thank our President, Dr. Aparna Bahiti, Madam, for for giving us opportunity to speak on this. Are my slides visible, please? Hello?
No, sir, you are yet to share your screen.
Just a minute. Are my slides visible?
Yes, sir.
Yes, sir.
Yeah. No.
Now, coming to importance of precision, we all witnessed this Operation Sindoor, how Indian Armed Force had carried out the precision at Nuhan Airport and Pakistan's many of the terrorist spots. So we all know what is the importance of precision. Just to take you in this regard, I would like to speak on precision in toric eyes. Now, let us first discuss what is the effect of astigmatism on the image quality. As you can see here, with a 1.5 cylinder and 3 diopter cylinder, this is the type of images the person would see, and this is the clear image which we see. So we have to get rid of this astigmatism. Now, coming to the prevalence of corneal astigmatism, there are 87% of patients who have got corneal astigmatism, right, ranging from 0.5 to 1.5 or more than that. And out of that, 50% of our cataract patients are potential candidates for the toric eyes. And these are the patients which also gives us the money. As Dr. Manish has spoken, premium patients ही पैसा देता है. So we can convert these patients for our money That is for the toric lenses. We can, like normal patient like 0.75 or more than that, we can take this patient into consideration for considering them for the toric IOLs. Now, as we all know that modern cataract surgery has become more of a refractive surgery, and thereby increasing our responsibility to fulfill high expectations of our patients. Now, myopia and hypermetropia can be corrected by the appropriate spherical paths, we all know. But there are many patients who have got astigmatism from 0.75 to 1.5 to 7 to 3 or 7 diopters. It could be corrected by the toric IOLs or by the LRIs or by the lasers. But LRIs has got its own problem, which is unstable, and which again regresses as the time grows. And with the lasers, we all know the post-op complications. Immediately post-op, we cannot use the lasers. So now, just going slowly on the components of toric IOL calculation, I'll just say that spherical IOL, there are two components. One is the spherical IOL calculations and another is the toricity. What exactly we are looking at? We are looking for the projected corneal cylinder after cataract surgery. For that, we need only two inputs. One is SIA, but nowadays SIA we consider as obsolete, because when we are going with a 2.2 millimeter incision or 2.8 millimeter incision, we consider SIA as only 0.2. And the another important point, which is which we take into consideration, is pre-op corneal cylinder. Now, these are the current consideration for the toricity calculation. Older thinking was like astigmatism was based only on the anterior corneal surface alone. But even if disparity, if it would occur in pre-op or the post-op refraction after the cataract surgery, we would attribute it to a lenticular astigmatism or a retinal astigmatism, because that in those days we never used to consider the posterior corneal astigmatism. But nowadays we have to consider the posterior corneal astigmatism, because if we do not address the posterior corneal astigmatism, we may land up in the overcorrection or undercorrection. And SI is supposed to be a vector because it consists of magnitude and also the direction. As we all know that anterior surface in the early life is with the rule astigmatism, and as the age grows, we shift it towards the against the rule. And posterior surface of the cornea remains unaltered throughout the life. And if the posterior surface induces around 0.7 diopter at 180 degrees Celsius, 180 degrees spectacle plane, sorry. Now, what if we do not consider the posterior corneal astigmatism? Because if we are going with the rule astigmatism, we may overcorrect it by 0.5 diopters, or if you're going against the rule astigmatism, we may undercorrect by 0.30 diopter. So we have to, in short, we have to be very precise for the posterior corneal astigmatism. Now, coming to the measurement of pre-op corneal astigmatism, we just have to know that all the toric lanes, whatever are available with us, they are gracefully coming with the plus cylinders only. So what we have to determine is only we have to determine the steep meridian of the cornea. And that could be determined by various methods like manual keratometer, placido disc, or corneal topo. But what we are using in our hospital is Lenstar 900, which is a very good, nice optical biometer. Now, these are the few gadgets which I don't afford to have in my hospital at the Yodmal, but we can use these as a corneal to measure the steep meridian of the cornea. Now, pre-op marking, this is a very debatable and very fancy thing. Many of us are using this as per their own convenience, like gravity marker, bubble marker. But I prefer mostly with the slit lamp marking, and preferably or with the the slit lamp properly calibrated. Courtesy to Dr. Ashish Sapkal, who is in our lecture today also. So we have to, I use the slit lamp marking as a BC AQ marker, and I usually go with a slit lamp, a thin slit, marking the slit lamp on the slit lamp, and marking at 0 and 180 degree with the anterior Purkinje image of a cornea taking into consideration. And then nowadays I've started using a toric app of Dr. Swapnil, where I just take a photograph of that patient after marking and send it to a server, and that server gives us a proper revalidation, we can say, whether the mark is at 180 or not. As you can see on the left side of my slide, you can see the marking which I marked was supposed to be 0 and 180, but as you can see, it is at 174. So when I'm taking the patient in the OT, when I consider this my mark as 174, and then I go to the anticipated my axis properly as taking this point into consideration. Then IL alignment, which we all do, like which is usually I do, what I do is first I do a gross alignment. I use a little bit of under correction by 15 to 20 degree, and after that after the OVD removal, I go for a fine alignment. These are the steps we usually all do. Everybody knows these steps. As you can see here, I'm just rotating the IL and trying to balance it at the anticipated or intended axis of the axis marker. What important point I would like to make here is I go usually on a 12 o'clock position again and just try to remove the parallax effect and try to see that whether the marks are coinciding with my intended axis. Now, these are the steps for the beginners. I can say gross alignment, OVD removal, fine alignment, and if it overshoots, again we have to go with the gross alignment. And when we are satisfied with the intended axis and the axis marking or IL placement, then you can nudge the IL down to the capsular mat, and if with the help of a tackiness of the lens, we can properly stuck that lens into the bag. Now the IL rotation have a very significant impact. Generally, for every degree of IL rotation, 3.3% of the lens cylinder power is lost. So complete loss of cylinder would be there if the rotation is more than 30 degrees. So we have to be very sure about the IL rotation. Now coming finally to my 10 pearls of precision, ensure that the patient is willing and promise less and deliver more. This holds good for all the premium lenses. I'll say you promise less and then deliver more. Then precise corneal steep marking, CCC, needless to say that proper nucleotomy, then proper CCC, accurate marking, and reconfirm the proper alignment to avoid the parallax error. Seal the incision well to prevent the shallow of the anterior chamber, and don't overinflate it. And another important point I'd like to make here is post-op. If you find any misalignment, do realignment within 2 weeks. After visiting Bardot had an astigmatism fixed dot calculator. I had two of this patient where I did some mistakes, and then again I have to go and correct it. And finally, I would like to just say that astigmatism correction is a game of degrees, and in that game, precision is the only winner. And I'm happy to share this screen with Dr. Saurabh Patwardhan and Mohantan, who are the bosses in the cataract surgery. Thank you, President. Thank you, Scientific Committee Chairman, Dr. Rahul. Over to you, Manish.
Thank you, sir. This is a nice painting. Sir is also a very great artist. Sir's painting is our souvenir in the Moscow this year. Sir, the toric discussion cannot be completed without a small closing comment of Dr. Ashish Sapkar, sir, who is the inventor of straight line marking.
Right.
Ashish sir. Meanwhile, Ashish sir is come to unmute. I will also like to mention Dr. Saurabh Patwardhan sir mentioned a special technique to implant a toric IOL in mid-dilated pupils. Saurabh sir is there?
Yeah. Hello, Manish.
Yes, sir.
Yeah. So my iToric app is now almost 11 years old. So in 2014, I started using iToric app, and after that, in fact, I have not done split lamp marking or any other bubble marking after that, and it's very accurate. And even in the meta-analysis, it has been noted as the #1 smartphone app in recently done survey. So I think as far as toric IL is concerned, the reference marking and toric calculation has now been almost solved. I don't find any issues with that. The only issue now remains is the post-operative toric IL rotation, which depends on not just your reference axis marking, but also the IOL material, IOL design, and the patient's eye. So some patients' eyes have bigger bags, that or their the biology of these capsule might be different. So in those cases, even the IOLs which are generally considered very stable tend to rotate. So only in those cases we need to re-rotate. I don't think the errors in marking or on table, minor errors actually affect the patient's outcome nowadays. For the on table alignment for small pupil, what I do at times is that I add one more mark using a 30 gauge needle. I just touch the surface of the IOL just beyond these 2 or 3 or 4 marks which the IOLs have, so that during surgery it's very easy. Even if the pupil goes down, we can still see those marks. And particularly post operatively, if we are in doubt, like now I have eye tracy, so I don't have to actually dilate the patient and see where the IOL lies. But if we don't have and the pupil is non dilating, post operatively it becomes little tricky to know whether the IOL has rotated or our calculations have gone wrong. So in those cases, these small marks, or these are actually not marks, these are just you touch the IOL surface, and that's enough for you to see under the microscope, and it will not cause any aberration to the patients. And the right time for IOL rotation is generally between 2 to 3 weeks. So I generally avoid re-rotation of the IOL before 2 weeks, because if you rotate very early post-operatively, it tends to re-rotate again, particularly in bigger bags. So it's better that you wait for at least 2 weeks or even 3 weeks and then only re-rotate the IOL, and you will find that the chances of re-rotation of such IOL is almost zero.
Thank you. Thank you very much, sir. Sir, any questions for sir?
Thank you, Purohit sir, for your excellent presentation. Thank you, Manish, for asking me to comment on this. As usual, Purohit sir has covered the entire spectrum, what a beginner has to do in order to get accurate. And Saurabh sir, with his comments, he has given his wisdom about how accurate these things are nowadays. In my experience also, using the basic things, they are very pretty accurate. But on and off, you are going to get some surprises, and these surprises are going to bite you if you are going in the realm of a multifocal toric IOL. So that is when all the question of accuracy arises for every case. So that's why my current practices are quite different than what is being routinely taught. One additional thing what I have found out recently is that since I've shifted to making capsular marks for toric IOL, is that the post-operative IOL rotation is actually very less as we used to think previously. Because I have a capsular mark, now I can actually see and measure the post-operative IOL rotation by measuring the IOL position and my capsular mark, since these marks are there post-operatively as well. So even the post-operative rotation that is very frequently talked about is not that big of a degree change in the rotation of the IOL. Another thing what I would like to say is that when you have a small pupil, there is a very nice device that is being made available by Dr. Sri Ganesh. It actually creates a impression mark in the center of the IOL by using a pressure type of instrument, and it stays in the center for about 30 seconds. So that is also a very good option to look at if you are facing with a small pupil and you want to be accurate for your toric IOL alignment intraoperatively. Otherwise, whatever has been covered has been excellent so far. Thank you, Manish, for asking me.
Just a quick comment about this toricity of the IOL. Of late, we have started doing this femto. I'm sure Saurabh would agree with me. With that Z8 Zima machine, we have that arcuate incision. So less than 0.8 diopter. For the last 6-7 months, what I've been using, even the multifocal IOLs, I'm pretty happy with that arcuate incision. Saurabh, if I can have your comment on the Zimmer Z8.
Yeah, I have not started using the arcuate incisions, but before, whenever I use the LRIs or manual correction, I always felt that it is not so reproducible. Femto arcuate keratotomies, the results as far as studies have also shown that are not like 100% predictable, and particularly in India, because we get these toric IOLs for very less cost nowadays. So I don't think that I will be using arcuate keratotomy. There are also incidences where the arcuate keratotomy can cause irregular cornea in the long term. So I personally may not prefer arcuate keratotomy in my cataract patient. I will go for a lower toric IOLs, which are not that expensive in that case.
Thank you very much, sir. Learned a lot
Subodh,
of things.
Subodh, just one comment on your considering the posterior corneal curvature
Yes.
while considering the implantation of toric IOL. How do you know about this posterior corneal curvature? And
Very
is it
good.
really, yeah,
This is a very good question, sir. But now, like the formulas, what we are using it in other formulas, we are not considering the posterior corneal astigmatism. But for the accurate posterior corneal astigmatism, we need pentacam and other devices. But for our case in Lenstar 900, what we are using it, we are using this universal Barrett 2 formula. There itself has got the posterior corneal astigmatism into consideration, and then only it gives the results.
okay. If you don't consider,
Yes.
your results will be variable or they will
Yeah.
be accurate.
They like I had said that if it is with the rule astigmatism, it may get overcorrected by 0.7, or if against the rule astigmatism, it may get undercorrected by 0.30 correction. In short, it is not accurate, and usually we then blame ourselves or we blame the lenses.
Okay, okay. Thank you, Subodh. Thank you so much.
In case of posterior corneal astigmatism, nowadays we have two approaches. One is the presumed posterior corneal astigmatism,
Yeah.
which is there in the Barrett's formula.
Yes.
And there is a total keratometry where we actually measure the posterior corneal astigmatism. So, but studies and even my experience suggest that both do equally well. So
Yes, yes.
actually, there is hardly any difference, and that can be probably because the instruments still are not able to actually measure the posterior corneal astigmatism, because optically we to measure posterior corneal astigmatism, whatever methods we are using, those rays have to pass through anterior cornea. So obviously the
Right.
anterior corneal astigmatism or anticorneal curvature is going to affect the measurement of the posterior corneal astigmatism. So even if we have TK in our IL master, and if in some center I don't have TK, sometimes patient come from other center to our center, we find that there is hardly any difference in the power calculation. So I think the Barrett has solved most of the issues.
Most of the problem.
Don't need actually any instrument to measure posterior
Yes,
curvature,
yes.
Right.
particularly for the levels at which our accuracy of IL power calculation presently lies, which is not more accurate than plus minus 0.75, even using the best of the formula. So if you have 0.2, 0.3 difference in the posterior corneal astigmatism measurement, it actually affects really less as far as
Right.
final outcomes are concerned.
Right. It doesn't have too much of
Another
effect on the final outcome.
Yeah.
It is said.
Dr.
That's what
Manish,
it is said.
Dr. Manish,
another
can I ask one question to Dr. Saurabh if time is permissible?
Yes, sir, please.
Yes. Dr. Saurabh, I would just like to know, like for example, if you got a lenses like T3 and T4 available with you, in one lens there is 0.7, like the residual astigmatism is showing plus 0.25 at 180, and another is showing residual astigmatism like minus 0.50 at 90. None of it is giving the accurate 0 residual astigmatism. Which lens you would be like minus at 180 or minus at 90 you'd prefer? Like in short, with the rule astigmatism, you'll prefer the lens T3 or T4, or you'll prefer with the against the rule astigmatism while implanting the lens?
Yeah, it's always preferable to leave a little bit of with the rule astigmatism. But again, as I said, when we are using such a low power cylinder IOLs, remember, like for example, T2 has a 1 diopter cylinder in the IOL, which corrects around 0.6 to 0.7 diopter on the cornea. Now, when the patient has say 0.5 diopter astigmatism on the cornea, its reproducibility and repeatability itself is very less, because all the keratometry instruments that we use are hardly accurate beyond plus minus 0.5. So even if in the same patient we keep checking, you will find that for low astigmatism particularly, the axis changes by plus minus 10 degree, and the measurement also changes by plus minus 0.5. So sometimes it will come 0.3, sometimes it comes 0.7. It's very, sometimes the 10-degree axis is there, sometimes it shows 20 degree. That's because at such a low level of astigmatism on the cornea, the tear film changes every time, and the measurement accuracy of the machines that we use itself is not that accurate. So finally, when you are using T2, see, all these, it's like we are splitting the hair, but for very low astigmatism values, actually these clinically doesn't make any difference finally.
Difference. Okay. Thank
And
you.
earlier wisdom was that we should not reverse the axis post-operatively. Okay, but we find that patient adapt. Like it's not a big thing. If sometimes by mistake you have shifted to maybe 0.75 on the other side of the axis. Earlier thought process was that patient will not be able to adapt to that, but we find that they adapt well. They hardly any problem post-operatively. They might require some refractive correction, but it's not so that they find something is unusual because their axis has been reversed.
Isn't it not good for living with the rule astigmatism for the near vision of the patient if it is mostly patients are above 50?
Yeah, basically we are living with the rule astigmatism because the natural age-wise progression is towards the against the rule astigmatism. So that's basically the outcome. Uh, see, whenever we leave any residual astigmatism, there is always a reduced contrast for the distance. So whenever we are giving more near vision to the patient, we are also decreasing the contrast for the distance or clarity for the distance. So ultimately, it's like a compromise.
Thank you.
Hi, Saurabh. Dr. Praveen here. So I just want to say that I would like to leave some amount of with the astigmatism because of many reasons. The two reasons you have already told, but leaving some amount of with the astigmatism will increase the depth of focus and increase the pseudo accommodation. Because in the English alphabet, the more vertical letters are there, and if you leave some amount of with the astigmatism, it's better for the near vision. And the second factor is the lens tilt. In many of the patients, when they have a crystalline lens tilt, in most of these patients have contributed the against the rule astigmatism. So it's always better to be more aggressive when we correct the against the rule rather than the with the rule.
Yeah, that's what I said. IOL tilt actually doesn't affect that much in the astigmatism. For example, you can calculate on Chat GPT. If we put 20 diopter IOL, okay, and the degree of tilt is say 5 degree. Usually we don't get more than that tilt. We'll find it's infinitesimally very, very small degree of astigmatism that it itself induces. So yeah, but that's what theoretically I think we have to try to put it on a little bit of but with the rule astigmatism side, which everyone agrees.
Yeah, that's true.
Sir, I think we should continue with our next presentation. I have Dr. Jay Bhopi sir for sharing us his wisdom on multifocal IOLs. Jay sir.
Yeah, good evening, everybody. Thank you, VOS President, Dr. Viral. Am I hearable?
Yes, sir. Yes, sir.
Yes, sir.
Yes, sir.
Thank you, Dr. Rahul, Dr. Viral, for giving me an opportunity today. I would be speaking today on optimizing visual outcome in multifocal IOLs. So as we all know, cataract surgery is now a refractive procedure. As compared to monofocal IOLs, multifocal IOL gives spectacle-free vision both for distance and near, thereby increasing the quality of life of our patients. Multifocal lenses offer the benefit of clear vision at various distances, but they also come with potential drawbacks. So patient might have bright visual artifacts like halos, glare, starburst, especially at night. This is due to the way light is distributed across the multiple focal points in the lens. While most patients adapt to these phenomena over time, some may experience persistent glare and halos. There might be positive dysphotopsias like glare, halos, starburst, and also patient might experience negative dysphotopsias like shadows or arcing lines in visual fields, often temporarily. There is sharpness of vision is slightly reduced in these patients with multifocal IOL, especially when compared with monofocal IOLs. Contrast sensitivity is also reduced, making it harder to distinguish details, especially in low light conditions. This is more common during driving, more so during night driving. So what we have to do with all these problems with the multifocal IOLs, we have to consider certain points to make our patients very comfortable in when the IOLs are multifocal. So we have to consider all these points: patient's lifestyle and needs. Always aim for post-operative emetropia. Aim for minimal or no post-operative astigmatism. Always evaluate dry eye in those patients. Specifically look for any zonular weaknesses. Rule out large angle kappa. Also rule out whether there is any retinal or macular pathologies. So understanding the patient need is very important. Ask for the reading habit, type of near work he is doing, ask for night driving. More chair time should be provided to these patients. A person who drives vehicle during night, multifocal IOL should be avoided. Counseling of these patients should be proper, like spectacle dependence will be reduced to these patients rather than saying spectacle free vision we will get. Always assure less and give more. Then post-operative residual ametropia is the commonest cause of dissatisfaction among these patients. So exact IOL power calculation is a must in these patients. Residual refractive error in patients with multifocal IOLs will be a disaster. Optical biometer gives exact IOL power calculation in these patients. Then coming to astigmatism, pre-existing astigmatism or surgical induced astigmatism. Pre-existing astigmatism can be due to either pterygium or corneal scars. So any corneal astigmatism of more than 0.75 diopter should be managed during surgery itself using toric with multifocal IOLs. Pre-operative keratometry by optical biometer is usually preferred. Corneal topography can give exact visual axis. So pterygium if present in these patients, it should be excised first, and after the astigmatism is stabilized, the cataract surgery is done in these patients. So preoperative evaluation and subsequent management of ocular surface disorders such as dry eye, blepharitis, meibomian gland dysfunction, these should be taken care of preoperatively. Post-operative dry eye with residual ametropia is the commonest cause of dissatisfaction among these patients. Then coming to decentration, IOL decentration or tilt may affect the distribution of light between the distance and near foci, compromising the visual outcome of these multifocal IOLs. Capsular tension ring can give good stability in patients having zonular weaknesses. Then coming to the sixth point, that is angle kappa. Angle kappa is defined as the angular distance between the pupillary axis and the visual axis. Slight temporal decentration of the IOL can cause pronounced photic phenomena in these patients, particularly in cases with large angle kappa. What happens is large angle kappa, it leads to the light might pass the center of the macula through other diffractive rings instead of the central area of the multifocal IOL, giving the functional IOL decentration, thereby leading to photic phenomena and surgical aberrations. More than 0.5 diopter of preoperative angle kappa should be carefully considered in cataract patients who are implanted with multifocal IOLs. Optical biometry gives an exact idea about if there is any patient having with large angle kappa. Retinal pathologies, this is the very important point. Preoperative OCT evaluation of the macula is very important if the patient is undergoing multifocal IOL surgery. In cases of significant or progressive pathologies, multifocal IOL should be contraindicated. Difficulty in fundus evaluation is also noted during vitrectomy, has been reported in eyes with multifocal IOL implants. Then coming to the 8th point, posterior capsular opacification. To prevent posterior capsular opacification, thorough cortical cleanup, round circular capsular axis, well-centered IOL, preferably hydrophobic, all steps should be taken to prevent PCO postoperatively. Because postoperative PCO is one of the most important cause for dissatisfaction in multifocal IOLs. What is the take-home message? Always when patient is undergoing multifocal IOLs, spend some time with the patient, understand his needs. Steps should be taken to make the eye emmetropic. Exact IOL power calculation is a must. Toric with multifocal IOL should be considered if the patient is having preoperative astigmatism. Then dry eye and ocular surface disorder should be taken care of preoperatively. All steps should be taken to prevent posterior capsular opacification. OCT of the macula to be done if there is any suspicion. Avoid multifocal IOL in cases of large angle kappa. Also avoid multifocal IOL if there is any zonular weakness. Thank you.
Thank you very much, sir. This is excellent coverage. Sir, one quick question as we are running short of time. Sir, how many percentage of your daily OT list or monthly OT list have a multifocal IOL patients? Because the area where I work, hardly 5 or 10 patients out of the 100 I can convert to the multifocals. So in general, I want to ask that whether I lie in this whole scenario.
What I usually prefer is multifocal IOLs. I usually prefer in female patients because these patients do not drive during the night, or female patients, housewives, all these patients I usually prefer for multifocal IOLs. If the patient asks for something more, they want for near work, some patients, those patients we consider for multifocal IOLs.
Manish,
Sir.
do you think that doing multifocal IOL is a great surgeon who is doing the multifocal IOL? It's not like that. You have to
Sir,
see the need of the patient.
Sir, many of the times I think it is a great
It's
thing
not
to
like
fulfill
that
the
you are doing
EMIs.
multifocal to each and every patient and it's something great. Yeah, it is okay, but you have to choose the patient among the patients, your patient, because the result does matter. Finally, patient does matter.
Manish, a quick question. I want to ask Anand sir, Gade sir. Please throw your light about will you be planning multifocal IOL in a post LASIK patient, because these patients might have more expectations about spectacle free vision, and if what are the things to be considered or kept in mind for planning multifocal IOLs in post LASIK eyes?
Shahrukh Khan patient.
Unmute, sir has to unmute. Gade sir, you have to unmute.
Sir, you are muted actually.
Now,
Now.
see, my point is, post LASIK cases, instead of calling it a multifocal, call it a presbyopic correcting IOL and go for EDOF. Here you are very comfortable. All that you need is very accurate your IOL power calculation that you have to confident. So you have to run certain sets of formula where you are confident about it earlier. Then it's a very easy game. Of course, you need pre-op lot of investigation. Other than that, apart from biometry, then patient have to have the very detailed corneal topography where you are considering anterior plus posterior cornea plus corneal aberrations also. Look at this. And regarding this, you know that what Manish was asking, that Manish asked one question to Dr. Bopi, that how many percentage of cases you operate multifocal, and then actually in a good practice, if you are operating say about 20 to 30% of cases you can convert. That's a good practice. And with your efforts, you can make this percentage on higher side. That is the answer.
Okay, thank you, sir.
20 to 30%.
I will have two more words.
What about what is Pradeep sir's take on these patients, sir? Like post-LASIK patients for multifocal IOLs?
Hello.
Yes, sir. How do
Actually,
you?
actually, I practice in a place. It's surrounding villages, and I don't get a lot of patients with this multifocals. So I am not the right person to answer this question.
Rahul, you might be knowing that I am doing the LASIK since 2004 in a laser vision, right? And
Yes, sir.
I say big no to the multifocal after post LASIK. Whatever the condition may be, no multifocal after post LASIK surgery.
And what about add-off IOLs in post-LASIK or
Cannot
post-refractive?
hearing.
Add-off, extended of focus.
Yeah, ADOF may be okay, but I don't think even ADOF is okay. Just put a good monofocal, that will be better. Since 97, I am doing the phaco. Since 2004, I am doing the LASIK. I know each and everything. But the monofocal, still, if you ask me which lens you are going to put in your eye, I will be preferring monofocal in my eye. I would like to wear presbyopic correction.
Recently, one of the superstar has had a problem with the post-LASIK multifocal lenses. We all know that, I think.
Yes, yes.
We should not name the surgeon and not name the superstar also.
It
But
was actually. It was not a multifocal.
it was EDOF, no VVT, I think. Like theoretically speaking, there are true K formulas and Schumacher's formula, but I have not experienced any such patient. But theoretically, there are formulas which we use post-LASIK.
Sir,
one of the problems of post LASIK patient is that now we are getting patients which were operated a long time back, when the machines were not probably that good. So we tend to get many patients with decentered ablations and very small optical zones. And these are probably not very good candidates. But in future, we might get candidates who are more suitable for doing multifocals or EDOFs. And so proper corneal evaluation before, and also it's a LASIK operated many years back. So cornea also remodels over a period of time. So
Yes,
we
yes.
have to make sure that, and also that every LASIK also reduces the contrast sensitivity in patient's eye. So if we are putting lenses which are going to further reduce the contrast, so it's a matter of numbers. And also finally it comes to neuroadaptation. So few patients are so motivated that they get adapted to even poor quality of vision post-operatively, while few patients are so finicky that even with good vision, they are not ready to adapt to certain minor issues that they have. So finally it comes to patients motivation, needs, and the physics, that whatever we can gather from the biometry.
Is there any difference about calculation IL powers in these patients, in post-LASIK patients or post-SMILE patients, or is it the same similar thing?
I feel theoretically it will be same, because SMILE also works in the same way as LASIK works. But recently Narayan Netralaya has published a paper. There might be some minor changes, because what they hypothesize is that the effect on the posterior cornea is slightly different in SMILE as compared to post LASIK. But I feel theoretically it should work the same way, because finally both work in the same way by flattening the central cornea.
Yeah. Thank you, sir. Yes, Manish.
Sir, at the end of nearly last session of this whole webinar, we have a dessert, Dr. Saurabh Pattodan sir's talk, my online guru, who have always maintained my moral while managing the grade 5 and grade 6 iatrogenic posterior polar cataracts. I mean,
Hydrogen.
so, sir, this happened many times, sir, with us. Sir, we are eager to for your session.
Okay, I will share my video. Let me see. Oh my. So I think there is some, it asked me to rejoin the Zoom, my laptop. Just give me a minute. I will just rejoin.
Yes, yes, sir. Meanwhile, I will something. Saurabh sir has designed his own grade 4 posterior polar cataract, a new nomination in this post, where the PC is already having a small breach, but still the anterior haloid is phase is intact. And sir has shared many wonderful videos on the YouTube how to manage such cases. And I tried few times while seeing such like Pohanta sir's and Saurabh sir's video. But many of the times at the end of the case, I finished up creating a grade 5 or grade 6 iatrogenic posterior polar defects. And I will ends drop. So this time again, it will be a great opportunity to learn how to manage such cases. The sir has always emphasized about the thought process while managing such cases and also while managing the complications. Okay, I think sir is back with the screen sharing.
Hello, is my screen
Yes.
visible?
Yeah. Yes, sir.
Yes,
But
Yeah, okay.
slides, video is not.
Okay, so in this video, I'll be just explaining a few thought processes when you have to operate on cases where there is already a breach in the posterior capsule. So, of course, we most commonly encounter that with PPC. So, let me first go through the thought process. So, as we know that we always, you know, describe posterior polar cataract as only posterior polar cataract when we are speaking with with our colleagues, but in fact there are four types of posterior polar cataracts, and the three types are described in this particular article by Professor J.S. Titial sir. Type 1 is when there is an intact PC and there is a clearance between PC and the opacity. Type 2 where there is intact PC in the periphery, but in the central part there is shadowing over the posterior capsule. And in type 3, there is a denser opacity, extensive shadowing, and there might be some bulge also in the posterior capsule and inability. And there is a fourth type also, which I will be also showing in this particular video, where just one moment, where there is already a, I will just show, okay, in the OCTs, I will just show the different types. So in type 1, basically, when you do anterior segment OC, you find that the posterior capsule is entirely intact. And in fact, all your presumed PPCs, if you do anterior segment OCT, it will be type 1 and they don't have any risks of posterior capsule rupture. This is type 2, where you may see that patchily at some places, it's not visible. The PC is not clearly visible. So it might have a higher chance. And this is a type 3 where you can see some slight bulge. And it's because of dense opacity, you cannot see the posterior capsule clearly in the central area. Now there is a type 4 also where the posterior capsule has already given way. So this is a new type which I have described, which is type 4 PPC, where PC is open and there is some lens matter which is already there in the Burgess space. Now let's try to understand through animation what are these types. So type 1 is basically there is a posterior capsular, probably a plaque, but there is a clear zone between the PC and that plaque, which means it's actually not a PPC. In PPC 2, the posterior capsule is not very clearly visible on OCT. So there are chances that PC might be defective. In 3, there is some bulge, but there is no rupture of the posterior capsule, which is evident on the OCT. While in case of type 4, the PC has already given way and the lens matter has already entered in the Berger space. So this is the type 4 and type 3. These are the two cases where the chances of nucleus drop is very high. But remember that all cases of posterior polar cataract, you always have anterior hyaloid which is intact. Okay. As compared to that, when you have a post-traumatic cataract, okay, when you have a post-traumatic cataract where it's suspected that the posterior capsule may be defective, these are the cases where there is a high chance that anterior hyaloid may also be ruptured. Okay, so this is a difference between PPC with a pre-existing PC defect and a traumatic cataract with PC defect. In PPC, anterior hyaloid is always intact. So there is always a chance that you can remove this nucleus and place the IL in the back. Okay, so if suppose PC is intact or not intact, but what causes rupture of the anterior hyaloid, that is more important. So two things which cause anterior hyaloid rupture is that excessive hydrodissection or pushing of fluid. Even hydrodelineation, if you are pushing excessive fluid, it can cause rupture of the anterior hyaloid. Second thing, not just pushing the fluid or hydrodissection, also pushing lot of fluid or OVD in the anterior chamber itself, causing posterior bowing of the lens iris diaphragm, can itself cause anterior hyaloid rupture. So these are the cases where the chances of nucleus drop are common. So that's why low IOP phaco is essential requirement for such cases where PC might be already dehiscent, or in cases of type 3 PPC where there might be already bulging PC behind. So in first case, you can see this is the case I am going to show. You can see on anterior segment OCT that posterior capsule is already ruptured, and that's what you see. Lens matter has already entered the Berger space around that posterior capsular plaque, which means the PC is already ruptured. Now, a few techniques which I'm going to show here. The first technique is that whenever you are doing capsulorhexis, always do capsulorhexis of 4.8 millimeter, not larger than that. Why 4.8? Because this is the most optimum size of the capsulorhexis, which allows you good optic capture. If it is larger than that, the optic capture is not always tight. Okay, so 4.8 is the number you have to remember. You can use manual capsulorhexis marker on the cornea or use the markerless. Mechanical hydrodissection has to be 360-degree and complete. So one of the commonest mistake that we do is that we may leave one clock or somewhere which is not mechanically dissected, and that is the area where entire epinucleus just sticks, and then you take very long time to remove that, the entire epinucleus, because it is stuck at that one clocker. So that mechanical dissection has to be 360. Now this first case is very soft cataract, so you can just go layer by layer, and I have done a good hydrodelineation, so I can remove the nucleus easily. All throughout, IOP I have maintained is 20, and that is the reason why even if it is a very young patient, the moment you enter your phaco probe or IA probe, you find that sudden deepening of the anterior chamber is there. But because I have kept 20 pressure, you will find never there was any deepening of the anterior chamber. So in posterior polar cataracts, deepening of the anterior chamber is more problematic than some shallowing of the anterior chamber. Okay. Now here you can see that the posterior capsule is already open, and the plaque which was there on the posterior capsule has actually now gone on to the anterior hyaloid. That's why when I did this posterior capsulorhexis, I thought that I can remove this plaque by doing posterior capsulorhexis. Once I completed the posterior capsule, I realized that the plaque which was there on the posterior capsule has already gone over the anterior hyaloid. And that's why I now removed the anterior hyaloid so that I could remove that opacity. I could have left it. It might have absorbed over a long period of time, but I wanted to clear it up for this young patient. So I removed. And you can see that lens matter still in the Berger space there. And once I have done the posterior capsulorhexis, I can easily place the IOL in the bag while doing visco aspiration. Again, make sure that you use very low IOP. So I've used just 20 IOP again for visco aspiration. So that maintains the IOL properly in the bag. There is no posterior bowing of the IOL anytime. This is the post-operative picture. You can see the PCCC and the anterior cap. So this was, I think, around 21-year-old patient with that ruptured posterior capsule. Now we will move on to other 81-year-old patient. He was diagnosed some 30-35 years back. That patient has a posterior polar cataract. So he waited for the surgery because he was explained that there are chances of complication. Now here I am going to use the oval capsulorhexis. For denser nuclei, oval capsulorhexis works very well because in case the nucleus tilts anytime, you can prolapse it out easily, and that smaller diameter on one side allows you to do optic capture still. Again, mechanical dissection, it's important to do all 360 degrees. So your movement from both sides should be covering all 360 degree. That is most important. Now for these slightly denser nuclei with posterior polar cataract, I have described this technique called, which is already published now in IGO. It is called sideways sculpting technique, where we do not rotate the nucleus anytime, but we do this plus sign just from one port. Okay, so I am doing the trenching, the first initial trench. Again, here 90% of the depth is essential. So you cannot do 60-70% depth and then think that the technique will be successful. Go till 90 degrees, almost till the posterior plaque. That is most important. And now I am doing the sideways trenching, where I create the perpendicular trenches without rotating the nucleus. Dr. Kiranjit Singh has shown the same technique. Okay, and what he did is that first he sat superiorly, did one trench, and then he sat temporally and did the second trench, which is also a nice way to achieve the 4 quadrants. Now here the trick is that you should split the quadrants not at the center but in the periphery. So unlike in trench and divide, where we try to separate it right at the center, I am trying to separate it from the periphery. Why in the periphery? Because I want the central plaque to remain intact till the end. Because if we try to, and also see that my moment of the separation is very small movement. So it's not like usual trench divide will be separate by 2-3 millimeter. It is just 1 to 1.5 millimeters separation, which is enough. And now once this is done, I have 4 quadrants which are there separate. Again, I have kept just 20 millimeters of mercury pressure. Here in these cases, the low flow fluidics is very important. So I have kept flow rate of just 30. So normally in my cases, I use 45, 50, 55 flow rate, but here I have kept it 30 so that everything becomes very slow. Remember, whenever we have very high flow rates, the same fluid jets are targeted towards the posterior capsule, which is already very fragile, and it can open up even an intact posterior capsule. So that is why low flow dynamics are very important. Now these 2 subaxial quadrants, I am going to lift them up. I am not going to rotate them, but I am going to lift them up. While lifting also, I have to make sure that I don't press on the posterior capsule anytime. So they are lifted up in such a way, and after I lift up one posterior capsule, one piece, I am going to inject Hylucoat, which is like viscoat, on the posterior capsule. So when I remove this third piece, I know that it is going to protect my posterior capsule. Again, low flow dynamics are used. Low flow allows that visco to remain in the bag longer, because I'm not going to aspirate that visco because of the low flow rate. Once the third piece is out, again I'm going to do OVD, put OVD. Again, I am going to gently lift up. Sometimes these pieces are already free and I don't have to do these dynamics. But when they are usually free, generally I know that it's not a true PPC, and that's why they just come out without trying this. But once you have this stuck kind of nucleus, you know that the PC might be little weak. So again, fourth piece, again I put Hylucoat in the bag and removed the fourth piece, again to re-emphasize low flow phaco, though I have little bit fast forwarded this video, but it is actually very low. And always avoid going towards posterior capsule even for this epinucleus. These posterior capsules are extremely fragile, unlike normal posterior capsules, and you will soon see if it is visible clearly there. When I am removing the cortex, you will feel that the central posterior capsule is much thinner as compared to peripheral posterior capsule. Okay, that's very common in posterior polar cataract, and that's why you have PC tears even after IL implantation, just by, when you hydrate a bit more and you tense up the anterior chamber, raise the anterior chamber pressure. Now you will find I have removed the epinucleus. You will find that the central PC, those, you can see those tiny dots. It's a very fragile PC and can break anytime during the procedure. So to have successful outcome on posterior polar cataract, you cannot be having perfect steps 99% of the times, because 1% or one split second where you go wrong, it will just split open. Okay, so you have to be full control 100% of the time when you are in the anterior chamber. Then only you may still have intact posterior capsule, or even if posterior capsule rupture, you may still have enough posterior capsular support to put the IOL in the bag. So these are a few tips and tricks which you can use when you have to operate on cataract with either already ruptured posterior capsule like in previous case, or when the posterior capsule is extremely fragile like in type 3 PPC, it is already bulging behind. Thank you so much.
Thank you very much, sir. It was really a nice treat to see these all cases. Sir, as we are already late, but I can't resist myself for ask few questions. Sir, when the machine is gravity-based, how to control the IOP? I means very much importance was given to a low IOP phaco.
Yeah.
So how to control the IOP when the machine is gravity-based?
Yeah, so for gravity-based machines, like if you have, then bottle height should be maintained at 60 centimeters. Now, for gravity-based machines, like with active fluidics, with low IOP also, you can use very high flow rate and very high vacuums. But with gravity-based machines, you just have to slow down everything. So you slow down the flow to 20-25, you reduce the vacuum to 200 to 300, and it should be extremely slow fluid dynamics. Then even say 60 centimeter bottle height will be sufficient, and you will be able to do that surgery.
Okay. Sir, you used a mechanical separator for from which instrument you used in it?
Yeah, it's like a iris repositor basically. So you can have a slightly broader iris repositor with a curved end. So you can go till the equator. Basically, this mechanical separation has to be till the equator.
Okay, okay. Sir, can we use a sideway chopping like we do a sideway trenching? Just
Yes,
by rotating the probe?
but the idea is not to rotate. Okay, but what you can do, instead of doing exactly 90-degree chopping, you can do like a V-like chopping. So you can do maybe smaller pieces in front, and then two large pieces will remain in the subincial area. Am I audible?
Yes, sir.
So, but only thing in chopping is that again you have to avoid complete separation till the central posterior plaque. Okay, am I audible?
Yes, sir.
Yes.
Okay, yeah.
Yes, sir. Yes, sir.
Yeah.
Yes. Okay, thank you. Thank you very much, sir, for this fantastic session and talk. I thank all the speakers who are here and gave us this opportunity to learn so many things. I will hand over the session to Dr. Shamik Mokadam, sir, Secretary, Vidarbha Ophthalmic Society.
Shamik sir,
Sir.
I'll just take a minute from you. Before we move to the end of this session, it is our honor to invite Dr. Aparna Baheti Madam, President, Yavatmal Ophthalmological Society. It's our true privilege that we had her gracious presence and participation of Yavatmal Ophthalmological Society for today's evening. May I request Madam to share a few words with us.
Thank you, Rahul and Viral. It was very nice talks. The all problems faced day to day by all ophthalmologists, and these topics were nicely covered. And thank you for organizing such webinars. These online webinars really help to attend all these important lectures and all. And thank you. We have great honor to have these stalwarts with us, Dr. Saurabh and Dr. Pradeep. Thank you so much. It was truly enlightening. Thank you.
Is Dr. Saurabh there?
Yeah.
Yes, sir.
Just one small query. Suppose you have a good hydro delineation, and is there any, do you need to do sideways chopping and sideways trains in those cases also?
Yes, no, sir. Because if you get good hydro delineation, generally we don't get good hydro delineation when the density of cataract is more, like grade 3 or grade 4. But for softer grades, if you get good hydro delineation, then we can directly do chopping. Because now we have already separated the nucleus from the epinucleus. Yes.
Right.
So generally, this sideways trenching I use for denser nucleus with post-polar.
Particularly when you don't have that hydro golden ring kind
Golden
of.
ring. Yeah, because if you try to do hydrodelineation in denser cataract, in fact, you tend to have a hydrodissection itself, and the nucleus starts tilting there only. So better to avoid trying hydrodelineation in denser cataracts.
Right. Thanks.
Thank you, sir.
Yes, Shamik sir.
Yes. At the outset, like to congratulate Rahul and his team, scientific committee, for a well-curated cataract surgery webinar. Very nicely conducted one, and Manish very well conducted it. Would like to thank our faculty, especially Dr. Pradeep sir, Dr. Saurabh sir, and of course our VOS faculty, Subodh sir and Jaivopi sir, for taking time out in and giving their special tips and insights on cataract surgery, especially for torics and multifocals that we discussed over here. Would also like to thank team Yavatmal Ophthalmic Society under the leadership of Dr. Bahiti Madam, and all our panelists and moderators and chairpersons who made this webinar a great success. And of course, I need to always thank all the attendees who really made this webinar a great success. On behalf of VOS, I would thank Entod Pharma and their respective teams for all the support that they have been rendering to us to conduct these webinars every month on a Wednesday. Thank you very much. Over to you, Rahul and Viral sir.
Yes. Thank you, sir.
Thank you so much.
With this, we end this webinar, right?
Yes, sir.
Yeah.
Thank you.
See you soon on one of the next Wednesdays. Soon.
Yes, sir.
Yes.
Yeah.
Yes, sir.
Yes,
Yes,
sir.
sir.
Thank you.
Okay. Bye.
Thank you. Thank you, everyone.
Thank you,
Thank you,
everyone.
everyone, sir.
Bye-bye.
Thank you,
Good night.
Saurabh sir. Thank you.
Thank you, everyone.
Thank you, Rahul. Thank you, sir.
Thank you, sir.